Okay, that should be right. Can you see the welcome screen?
Yes.
Okay, perfect. Okay, so I'll do an intro in a minute on my bio slide, but I'm an amateur photographer, and that's just a shot I took of the pond at Madison Square Park where the office is.
It's awesome.
It's your welcome slide. Okay, so my background, I'm a psychiatrist. I trained at Mount Sinai, general adult psychiatry. I did 2 years of general surgery before that at LIJ, actually, though as a child, I wanted to be a psychoanalyst, and I'm also analytically trained at the White Institute. I started doing TMS in 2010. I've always loved neuroscience, and with a procedural background, I was really intrigued. And seeing that it was really hard to treat, especially depression, like lots of things, but depression is really hard to treat fully. It really is. And I do a lot of public health thing and not for public health and not for profit, public facing and not for profit work. So I have a podcast and a blog. There's some stuff on TMS on my blog. And I do work for as a board member for Vibrant Emotional Health, mainly related to disaster mental health services. If anyone has a burning desire to go to a disaster mental health conference on resilience, we're hosting a conference at the beginning of October called We the Resilient in Nashville through Vibrant. That's really brief bio for me. So TMS, as I mentioned, I started doing it in 2010. I had a friend I trained with who was researching TMS, and he was telling me about it. And in 2008, when TMS got FDA cleared, I started thinking about, getting involved. And then I kind of studied and watched for a few years and then got involved in 2010. I took a break for a few years because in 2014, I founded a group called Neighborhood Psychiatry, which I exited that group, and now I'm back in solo private practice. And it's been incredibly gratifying actually getting back, not just into private practice, but getting into TMS again, because there's been some important developments in the field. Though the public still remains kind of like largely in the dark about TMS. It's kind of curious, and I think that'll shift because of the way the marketplace is shifting. TMS is non-invasive, meaning that there's no, even though it's a procedure, there's no penetration of the skin. There's no surgical component to it. There's no IV required. There's no anesthesia or sedation required. There's no recovery. And for major depressive disorder, there's other areas you can treat. We're mainly targeting the left dorsolateral prefrontal cortex. That's like the on-label target for treatment. Okay. Scope of the problem, World Health Organization is really close to 300 million people have depression on the planet. In the US, that number is pushing 25 million, and only about half of them are identified as having depression, and about half of those actually get treated for depression. And so there's just a large amount of untreated depression, and it's tending to get worse over time. And we're seeing worsening mental health across the boards on average over the last few years, and especially among adolescents. But the Surgeon General just highlighted how much stress there is for parents too. So, it's a tough planet to live on in 2024. I think that's part of it. If you look at TMS and you look at medication responses, we often talk about the STAR-D trial. Has everyone heard of this trial? So STAR-D is often referenced. It was a multi-center trial where they conducted a naturalistic study of how people respond to antidepressants. And so they treated many, many patients, and they kind of did what you would see in the community. These were not patients who were highly selected, like there were not a lot of exclusion criteria. And you would give them an SSRI, and then maybe you would switch or add something like Wellbutrin or lithium. If that didn't work, maybe you'd add bigger guns. What they found is, so overall, the remission rate for major depressive disorder for all medication trials, 1, 2, 3, 4, 5 or more, maxed out around 36% remission rate. And that's what people say, kind of the 30% rule. 30% of people respond great to antidepressants, another 30% have an okay response, and 30% don't respond at all. At the same time, the side effect profile gets worse with each trial. And so you run into a bit of a problem there. And so TMS is something that can help a lot, and things like ketamine and psychedelics maybe as well. ECT is still kind of the gold standard with something like an 80% response rate, but it's not super popular, even though we know it works really well and is life-saving. So if you look at this is a PET scan of someone with depression, there's global low activity throughout the cortex in depression. The depressed brain is on the left. And, it's kind of a whole brain problem, though there's differences in different areas. The question is, how can you treat the whole brain with a targeted treatment like TMS that can access the cortex? Medications, treat the whole brain, the whole body as part of the side effect problem. ECT, which TMS doesn't work like ECT, ECT uses, direct electricity to cause a generalized seizure. What TMS does is it targets part of the cortex, the dorsolateral prefrontal cortex. So if you look at like the bottom middle image, the bottom left image, the bottom right image, you can see the part that's kind of near the surface, the upper left-hand corner, is the treatment area. And these are patients who, when their depression has resolved, you can also see that deep brain structures are also networked into the left dorsolateral prefrontal cortex. So the way I usually think about TMS is it's not really like the left dorsolateral prefrontal cortex is the depression area of the brain. It's actually more like a deeper area in the subgenual cortex that seems to be a core node in the depressed brain's network. But you can use what are called cortical windows to treat the whole brain network. And indeed, this study from 2008 shows that when you treat the surface of the brain, there's distributed changes throughout the brain in responders. Okay. So any questions before I go on to a little bit about a little more about how TMS works? And yeah.
I'm curious how did we discover that was the cortical entry point? Why, was it just trial and error that we got to it? That cortical window, I think, as you described it.
Yeah, that particular area, the left dorsal, there was, theory behind it to guide the choice of that area going back to the 1980s, because we know that the different areas of the frontal cortex are involved in executive function and different aspects of executive function. The original observations were based on patients who survived strokes, because they found that people would get depressed if you had a stroke on one side, and they would get more happy or manic if they had a stroke on the other side of the frontal cortex. And so there was an observation that there was laterality. So basically, if the left side is relatively less active than the right side, people are more depressed. And then subsequent studies have shown that out, though it starts to get more complicated. One of the things is the left dorsolateral prefrontal cortex interacts pretty strongly with the anterior cingulate cortex, which is directly underneath it. And the anterior cingulate cortex is an area of the brain that's very much involved in signal discrimination, conflict resolution, judgment. You see abnormalities in the anterior cingulate in people with complex trauma and things like that. And some of the studies of accelerated TMS suggest that that's one of the main routes through it is to the anterior cingulate. And some of those studies will look for correlations between the different brain regions' activities, but there's other studies that don't find that same exact correlation. In the future, what we would like to see is something more individualized and precise. Maybe down the road, we'll be able to do some sort of functional resting state imaging that provides a more individualized treatment protocol. This is also the case, we'll talk about it in a minute, for OCD as well, because OCD seems to have, right, how are these diagnoses done, right? They're not based on biology. There's not different biological types of depression. There is research looking at that. On my blog, there's a recent study that found 6 different subtypes of depression. There was another study that found 4 subtypes of depression. Based on objective data like neuroimaging and cognitive testing and things like that. So at some point, then that's true for OCD. There's different types of OCD probably based on different brain networks that are involved. And so in principle, we could target that more in a more individualized way. But the DLPFC seems to work well for depression for almost everybody so far. Okay, so that's based on empirical data as well as clinical observation. And so high frequency TMS causes brain area to get stimulated. What it does is the changing magnetic field is Faraday's law. If anyone remembers Michael Faraday from physics, if you have a changing magnetic field moving through an electrical conductor, it induces a current. And so that's enough of a current induction at treatment strengths. The coil that we use for TMS is about 1.5 Tesla. That's about as strong. An MRI by comparison is 3 Tesla. So it's what I like to call a medical strength magnet. And that is enough within that narrow brain region, that targeted brain region, to cause the neurons in that area to fire, but not beyond that area. And so unlike ECT, it does not cause a generalized seizure. Seizure is a very, very low probability risk of TMS. And so with standard TMS, which is 4 to 6 weeks of daily treatments that are typically 30 to 40 minutes long, we have observed like at least a 62% remission rate, which is about twice as good as meds altogether, and much, much better than a second, third, fourth, or fifth medication. So you give people a chance at remission. And for those people who don't remit, the overall rate of response, which is defined as at least a 50% improvement, is 83%. So overall, 83% of patients will see at least a 50% improvement in symptoms. And this is with standard TMS. We'll talk about accelerated treatments in a minute. TMS is also now approved. The machine that I have is currently the only one approved, the NeuroStar machine, for treatment of depression among adolescents, among teenagers 15 and up. And this is CDC data from that was posted early in August that shows that the mental health crisis among teenagers is really strong, especially girls more than boys, but high among all of them. And so one of the interesting things about TMS for adolescent depression is that the FDA approved it as a first-line treatment, which it's not yet approved as a first-line treatment for adults, but for teenagers, it's considered an alternative to trying meds. So if you're making a decision about treating a teenager, if I'm a parent of teenagers, which I am, I might think, okay, if TMS works, that's great. Like maybe we'll need maintenance TMS, but they won't be taking any meds. They won't have side effects. We don't really, there's some concerns about how antidepressants affect the attachment system, all that kind of stuff. So you might think, okay, it's really worth a try because it's a cleaner treatment, doesn't have side effects. You may need maintenance like you do with meds, but it's less frequent. Maybe it's better, fewer side effects, no side effects, et cetera. And so it's really interesting, though, that the FDA found the data compelling enough that they approved it as a first-line treatment. If you contrast that with the hesitation and caution they're showing with treatments like MDMA recently, it shows you sort of one of the differentiating factors. One of the reasons I like TMS is because it is really well studied and safe and much more, let's say, medicalized. Like I feel much more comfortable offering it as a conventional treatment with clear guidelines. So it's cleared for teenage depression. Also, there's indications for OCD. I mentioned earlier, it's thought that there's several different circuits involved in OCD. And there's different machines for treating. TMS also has an OCD indication. We treat the dorsomedial prefrontal cortex for OCD, which is just neighbors with the dorsolateral prefrontal cortex. And what that does is it allows that region of the brain to interrupt cortico-striatothalamo-cortical loops. So it's cortex, the striatum, which is the habit area, the thalamus, which is like the switchboard of the brain, back to the cortex. And OCD and other conditions that have that type of obsessive compulsive repetitiveness have these reentrant loops of brain activity. And if you can interrupt them, those symptoms will get better. And so that's how we can target that brain circuit with TMS. And with OCD, we see significant improvement in symptoms. It's much harder to treat OCD to get full remission. We know that OCD tends to be chronic, very hard to treat. The data is really like consistent therapy and medications help, and it's hard for people to do the practice of the CBT typically. It is very difficult, especially for patients who lack insight. But TMS can give you a significant reduction in symptoms, usually in addition to meds and therapy, which enables patients to make progress. And for OCD, the treatment goal is more like relief of symptom and severity. It's great if you can get a full remission, but if you can give a 50% reduction in symptoms, the person is getting a few hours a day back and a lot more productivity. In the future, it would be great to have the kinds of treatments that I'm about to talk about for OCD that we're starting to see for depression. Okay, so I won't take time on the slide, but the top line is 95% of people who get TMS are able to complete it. The main side effect is some discomfort under the treatment coil. And again, 95% of people don't need to stop TMS because of that. Okay, so the typical treatment session is kind of very comfortable chair that reclines. Patients' heads are cradled in the head cushion. The head cushion that you can see here, both the head and the treatment coil have a measurement system that allows us to replicate the positioning of the head and the magnet, this exact same every time. It's all stored in the computer. And then the patient just gets, basically gets in the chair. We position their head. We place the coil in the treatment area. And we conduct the treatment once it's set up after the initial planning sessions. And they really just come in every time. It becomes very routine. The first day or two, people, it's unfamiliar, people are nervous. What I've seen is usually with standard TMS, which is a few weeks long, by the middle to the end of the week, it's routine. And sometimes we have to keep people from falling asleep, believe it or not, because it doesn't work as well if people are asleep. But believe it or not, because it gets so routine that they will just fall asleep while they're getting stimulated. And sometimes at the beginning, they're like, I had one patient who it hurt quite a lot. And by the end of the first week, I said, so how's your pain doing? And she didn't even remember that it had hurt. It was quite interesting. A lot of it is anxiety, right? Pain has a strong subjective component, and the unfamiliarity of a treatment like TMS enhances that. People are very used to taking a pill, right? And so the hardest thing for patients, which isn't that hard, but a lot of times for people, especially if they're severely depressed, is to keep showing up because they feel like nothing will work, they don't deserve it. A lot of times we get the family involved. It's really important. And then they start to feel better and they're quite happy they did it. Okay. And I'm going quickly because I want to leave a little time because we have a hard stop at 12:45.
That's what I had scheduled us for, but if we carry over, whoever needs to leave at that point obviously can.
I'll try to wrap up and leave a few minutes. Okay, so recently, and this has been on the deck for years, but so in 2022, a group out of Stanford developed something called Saint TMS, which is an accelerated 1-week protocol, and they use an MRI to locate the treatment location, and that refers to that anterior cingulate cortex measurement. But it turns out that you can use standard localization techniques. I won't go into detail, but they use EEG coordinates and trigonometry to determine the treatment location, work really well. And this data was published a few weeks ago, basically last month. This is a treatment protocol that was developed on the machine that I have that we've done already with phenomenal results with people who had complex trauma and years of treatment-resistant depression, unable to really get their lives moving along. So what we do is we give the standard, protocol is 36 sessions that would usually be given over 4 to 6 weeks. We do that over the course of a week. And instead of using 30 or 40-minute sessions, we use something called intermittent theta burst, which are 3-minute and 20-second protocols. And you can read my recent Psychology Today blog, goes into details on what theta burst is. So I won't take the time now, but it's a higher potency treatment that has a different magnetic pattern than standard TMS. And it's like a higher potency magnetic pattern that resembles an intrinsic pattern of the hippocampus. And this is a problem called neural engineering, which is really interesting. Not all magnetic fields do the same thing to neural tissue. Some of them just work a lot stronger. And so intermittent theta burst is just much more effective. And so what that allows us to do is it allows us to give people 36 sessions in a week because they're only 3.5 minutes long. So you can do it every hour with a lunch break. And what we see there is at least 70% remission rates by the end of 4 weeks out. And by the end of the first week, 55% of people are already in remission, according to this pilot data. What I've seen in my practice so far is that patients have gotten a full remission, usually within a few days. And then they get some benefit for the remainder of the week. With TMS, a lot of it is you get the initial response and you want it to persist. And what the data shows is more than targeting the treatment location with an MRI, it's the number of sessions you get and how closely together they are placed, which are the strongest determinants of treatment outcome. And so, again, this accelerated protocol, it's really been a game changer, actually seeing patients respond to it and doing it. I was familiar with the data, but one of the patients I treated, I've worked with personally for about 10 years. And, I have permission to talk about these treatments. She's been in therapy, DBT, CBT, psychodynamic. I've been working with her as a therapist for the last several months. We've tried lots of different meds, and including antipsychotic augmentation, and she just could not come out of the depression. And she came in after the first day. She came in Tuesday morning a few weeks ago and said, "I haven't felt this good in 5 years. I wanted to get up and do things," and she has. It's now been about a month, and she's all these things that she hasn't been able to do. She's going back to work. She's starting her own business. She's fixing stuff in her marriage. She's parenting in a different way. And so far, she hasn't needed any kind of booster or maintenance treatment, but we just monitor closely for that. So it really has been a game changer. The only time I've seen patients respond like this is rarely with medications and with ECT, except that no one will get ECT. So I've only seen that really in hospitalized patients. And so to answer some of those insurance questions, most plans have coverage for TMS. People usually have to have failed CBT and at least 2 medications. Accelerated TMS is off-label, but we try to get it covered because depression is covered. OCD is on-label, but most TMS companies that I've seen don't have an OCD plan yet, but we can often fight for a single case agreement. That's kind of the insurance landscape. I'm going to skip the demo video just in the interest of time. We talked about safety. Where'd the maintenance slide go? Did I miss it? That's weird. Oh, there it is. Okay, can everyone see that? Okay, good. 12:32, doing great. So it's hard to get, like, I can't find really coherent numbers on what percent of patients end up needing maintenance. The most recent study was a meta review, and what it found is that maintenance usually works. So for patients who are TMS responders and they start to relapse, if you treat them with standard TMS, it's like another week. Give them an additional week or two. With accelerated, we don't know yet, but it's probably a day or two of accelerated. They will, the majority of them, like almost 80% of them, will regain their treatment response. And then who needs maintenance is really what I've seen in doing TMS is it's less than 50% of people need some kind of maintenance. And then that's usually a few sessions a month. But what you do is you work it out based on the patient's clinical response. So it's a little bit like dosing a medication or like doing ECT maintenance. You find the minimum number of sessions that holds them. And to that point, yeah, maintenance is not usually covered, but insurance companies will cover like a retreatment. That's usually been the case. But what you can do is you can sometimes get the retreatment covered, and then you don't use all the sessions. And so you get some of those approved sessions and use them for maintenance. And yeah, like I said, the most up-to-date reviews are meta reviews. There's been many small studies of maintenance, but TMS is still a relatively new treatment that data hasn't been fully collected. I think it will be. You'll see in the next 5 years or so. One thing in terms of TMS development as a treatment modality is it's been announced publicly that Neuronetics, and there's a few different manufacturers, but Neuronetics is kind of the largest one, is going to be, has planning to and has announced the intent to acquire a TMS practice group called Greenbrook TMS, which has about 120 treatment centers. And so that will help, because in addition to kind of the clinical model, right, they get all this billing and credentialing know-how. And so what we've been doing since TMS started is essentially also doing advocacy. So whenever I treat patients, we try to get a prior authorization. Even though I know OCD, like I spoke with Cigna, or was it Aetna, and they said, we know OCD is FDA approved, but we don't have an indication for it, which of course is wrong. Like they kind of should and have to. And then the person I spoke with said, well, I don't do TMS. We used to have a TMS unit, but they dissolved it. I don't know why. So we do that advocacy. And as I said, I think you'll see in the next several months that TMS starts to develop more visibility and more awareness. For the first time ever, it was actually at a parents' meeting at the new school like a month ago. I actually met someone in the wild, another dad. What do you do? I'm a psychiatrist. I do this and that. He said, oh yeah, I had TMS and it saved my life. But that was the first time since 2010 that I'd met anyone IRL who'd had TMS. The patients we've treated are eager to let people know about it as well. And so a lot of the videos that you'll see, there's a couple on my website, are patients who have had TMS and who really want to help people get TMS because it saved their life. As well as a lot of the people who actually work for the company have received TMS and then want to go into the field. So good. We've left a few minutes. Sorry for talking fast, but I wanted to leave some room for conversation.
Thank you. Thank you so much for that, Dr. Brenner. That was awesome.
Yeah, my pleasure. Thanks for inviting me. I'll just share those in case you want to catch the codes.
Yes. And so I've got a list of questions here, but I'm not the important one. Anybody want to jump in with a question?
Yeah, Dr. Brenner, something I'm curious about. Did you, and I have two, we had different equipment. We had BrainsWay. And one of the things about OCD that was a little bit intimidating in treating is that you actually have to trigger anxiety before doing the treatment. Is that the way you're doing it as well?
Yeah, the protocol that we use, and when I was doing the training last year at Duke University, this is similar to what Duke is studying right now, is they evoke the symptoms during the stimulation to about between 4 and 7 out of 10 intensity. I much prefer the patient to have an outside therapist working with them, but you can definitely just do that with the patient because they'll know what triggers them. And that helps to recruit brain circuits, is the thinking, is that when you evoke the symptoms, then in combination with the brain stimulation, it will recruit the circuits of interest more effectively.
Gotcha.
And you're getting a dose of exposure,
Exactly. Right.
which a lot of times patients, as I mentioned with OCD, as you know, have trouble adhering with treatment protocols with therapy.
speaking of therapy, are you finding or have you found that people do better if they're seeing a therapist and in TMS? That they're
Yeah,
doing both
absolutely.
together?
My philosophy is really TMS bends the developmental curve. Like all the patients who I treat, I'm a traumatologist and a psychoanalyst as well. There's longer standing problems. So on a simplistic level, what I tell is it's kind of like getting your rotator cuff repaired. So keep your weight off your brain, like work on what's important, establish positive changes. And then for patients who have been struggling with sort of deeper issues for longer, when they're not depressed, they can do better work in therapy. A lot of times because treatment for depression, the standard is really partial treatment. It's very unusual for people to have a full resolution of depression. Therapy is helping patients to cope with their depression. So for some patients, if the only reason they're in therapy is because they have depression, they may not need therapy. But the vast majority of patients who I treat, TMS just facilitates their therapy, and therapy is really important to facilitate their not just recovery from depression, but optimizing their response to TMS and helping to maintain it as well. Because one of the things that triggers relapse is when people go back into their old patterns, and they have an opportunity when they're not depressed not to repeat stuff. And so I work
Gotcha.
really closely with therapists actually for that reason. I definitely don't see TMS as a replacement. I think it's a way to augment people's development and help their therapy along.
Sure. One more quick question and I'll be quiet. Something that I saw a lot is that when people start, after say a week or a week and a half of TMS, not a lot, but a reasonable percentage said, I'm feeling anxious. And what it turned out to be is they were actually just having more energy and they were
Yeah.
mislabeling it. Do you see that in your
I
practice?
probably don't see that because I think because a, a therapist, I provide a lot of psychoeducation so
Huh?
that people are less likely to misinterpret those cues. But I can certainly imagine it happening. Yeah.
Awesome. Thank you.
Yeah. Thanks for the questions.
Any
Go ahead.
any data, Dr. Brenner, around just how many people have had TMS, like and sort of what the trend lines are on that?
Yeah, I don't honestly know the numbers off the top of my head, but many, many millions of sessions at this point have been delivered with an excellent safety profile and the kind of efficacy rates. The Neurostar system is definitely the most commonly used one. The deep brain TMS is interesting to me. I've spoken with their company many times. I'd say it's more like broad than deep, though the magnetic field goes a little deeper. The type of magnet they use covers a much bigger field. So you get into this discussion about kind of targeting versus shotgun. And you can imagine that if you don't want to be concerned about targeting, then you can kind of hit a big area and you're more likely to get something. On the other hand, there's different brain areas and the science gets more complicated, but millions of people have received TMS sessions. Um, and that amount is just been steadily climbing. If you want numbers, I'm sure I can pull them up for you, but I think of that almost as more as marketing data. But it is a lot of people and there is an excellent safety record.
Do you find that the treatment appeals to people who might be anti-medication, for
Yeah,
example?
there's a subset of people who like want TMS instead of meds. And, like we said, for adolescent depression, there's an indication for that. I think TMS is safe, and even without meds, it's still quite effective. But the data on those remission rates, I would always tell the patient that data is for people who have at least one medication on board already. Um, and insurance may not cover it if they haven't, failed medications, but it's safe and effective. It would be off label, but if someone wants to try that instead of medications, I think it's a very understandable decision because if it works, you're going to know within like a month or two at the outside, and you may spare yourself taking medications if that's something you don't want to do.
Thank you.
Can I ask a question?
Yeah.
Dr. Brenner, first of all, thank you very much for a very clear and really helpful summary of the data, and also, very, very, I must say, encouraging. It almost sells itself and really makes me think of a lot of patients that really could benefit more than I thought before. And you were saying earlier about that, between a first line approach that it sounds like more and more that's actually being considered versus what the insurance agencies require, which is, you said, failure of CBT and medicine. So where would you stand on that? Like, would you, does it make sense also the first, see how things fail and try other things first, or do you advocate? I think you said for adolescents you would advocate a sometimes as a first line approach. Would you also consider it for adults, or how do you decide? Like, there's so many patients I want to send, how do you filter that out?
Yeah, I am. So my philosophy is very ethically grounded. I do feel enthusiastic about TMS. I'll share a couple of links in the chat. It does better than medications. The data, if someone's okay, what's the data? Then the data is that if you've had a few meds already, it makes very clear sense clinically to try TMS. The emerging data is the sooner you do it in the treatment algorithm, the better. Because once people have depression for a while, it gets harder and harder to treat. They have more and more meds. There's more and more side effects. The depression becomes entrenched. It's better to nip depression in the bud. Their whole lifestyle changes, right? Their life gets organized around it. There's a lot more rather to unwind once people have been chronically depressed. If someone said, "Oh, same question, I'd rather do TMS than meds," I would tell them I can't advise it on the basis of the existing data. It's not indicated for that, but I think it's a safe and reasonable decision because TMS is very low risk. Now, if they needed to get like brain surgery and maybe it'll help, but it hasn't been well studied and you won't need meds, I'd say hold off because the risks of brain surgery are high. But the biggest risk with TMS is a bit of time and really the financial investment because insurance is probably not going to cover it if they haven't met criteria. And meantime, we don't have the full data. So however, I do think it's likely to help people. I would give them the best education that I can and let them make that decision.
What is the financial investment if it's not covered by insurance for the accelerated versus the traditional course?
Yeah, I won't quote my rates, but the range I've seen in the market is anywhere between unusually, but on a low end, 15,000 for the week-long treatment, up to 25,000. I land kind of in the middle. And people are charging per session, like for standard TMS, depending on where you go. I've seen a range that clusters around 400 per session, something like that. But there's a lot of variability.
Great. So we cruise past the 12:45. So if anybody needs to drop off, absolutely. Thank you for joining. And if we have other questions for Dr. Brenner, obviously we've all got his contact info, so we can send that along directly. Is there anybody else that wanted to get a question in overtime?
I'd like to do a quick one if I could. Dr. Brenner, do you have thoughts about other brain stimulation modalities like CES, TDCS, those non-FDA approved things?
Yeah, I've looked into them a decent amount. The non-specific CES cranial electrical stimulation, I think the data is equivocal. There's a lot of anecdotal data. Those companies market really strong. Patients like it, but I'm not sure if it differentiates in double-blind studies, if there are any. TDCS, transcranial direct current stimulation, I looked into it a lot. Marin Bixen is at CUNY in the Department of Neural Engineering. He's a brilliant guy. I think TDCS has some interesting applications, but the data for depression is also equivocal, not really clear cut. They're also looking at it for military applications because you can use it to alter like information processing and improve things like target recognition. It's also been shown to change moral judgment depending on what area. TDCS does not cause depolarization. It doesn't make neurons fire, but it changes the probability of firing depending where you put the electrodes. And it basically uses a 9-volt battery. It's a 2 milliamp current, but it's direct current versus some of the AC ones. There's also photobiomodulation, which is pretty interesting. It uses near infrared light, which can penetrate into brain tissue. It's also useful in healing, in tissue healing applications. I think there's promise for that, but there's a lot of equipment and not as much data. Focal ultrasound stimulation, FUS, can also reach deeper brain structures. And the mechanism of action is interesting and kind of well known. It's not ready for prime time. And there's a lot of interest in stimulation. There's light stimulation of the retina as a window into the brain. And then I think neurofeedback is actually quite interesting. Again, neurofeedback's been around a long time. There's not a lot of well-designed studies on it, but there are a lot of people offering it. So there's pros and cons of medicalizing something. With TMS, I like that it's been medicalized because even though there's a lot of noise and it's a lot of commercial stuff, they still need to meet basic criteria to get approval done. And I do think there is something to that. But I think brain stimulation in general is really fascinating. Unfortunately, there is a lot of noise in the system, so people can really go down a lot of blind paths.
Thank you.
Yeah.
I have a question. Do you know much about TMS for PTSD? I mentioned that I work for the VA, and PTSD is my primary specialty there. I know there's been talk about it on listservs, and usually they say there's not sufficient evidence for or against.
I know psychiatrists who work in the VA, and there are some of them who use TMS very routinely for PTSD, and it can be very helpful. People also will ask about autism. If you treat the depression, people are going to get better. Let's say you're only treating the depression. Core symptoms of PTSD are trickier. Bilateral stimulation, the right and left dorsolateral prefrontal cortex. The last data I saw that had the best evidence for PTSD, it's off-label. And I think like OCD, you would want to combine that with evidence-based therapies to get the maximum benefit. It also depends on which symptoms predominate, whether you're more on the, the activated versus the high activation versus the low activation, vigilant versus dissociatives. You may change response. The studies of depression do show that anxiety symptoms are significantly relieved. And likewise for autism, you can treat the depression, you can get some anxiety relief, but trying to figure out the core symptoms, I would tend to agree. However, I think it can offer relief for people with PTSD. It's an off-label treatment. And I would set really clear expectations for patients, especially in a veteran population, because of how much they deserve better treatment. But like I said, I know people who work at Walter Reed, and they basically have said they do TMS on everyone because they have it in the hospital. It doesn't cost anything.
Yeah.
It often helps.
That makes sense.
But
thank you.
Especially for complex PTSD, I just think it's a lot more nuanced a conversation.
Yes. Yeah. Which is a lot of what we see. So.
Yeah, exactly.
Yeah. Thank you.
You're welcome. Thanks for the question. Yeah, I treat a lot of PTSD, so I appreciate it. Anything else? Yeah, feel free to reach out. Corey, thanks for the time. Thanks everyone for showing up and giving me your lunch hour.
Thank you very much.
Thank you.
Thank you so much. We really appreciate it.
Thanks. My
All right,
pleasure.
have a
Have a
great
good day. Bye-bye.
Bye, guys.